Functional baselines are baselines that we take in an orthopedic evaluation that are a little bit more subjective than the other objective baselines that we take. In part 2 of my orthopedic evaluation, I'm going to be taking orthopedic musculoskeletal baselines like range of motion, strength, nerve tension, balance. Functional baselines, in comparison to those, are more subjective because we're typically looking for a report of pain. Not always. Sometimes we're looking for a report of instability or stiffness or an inability to do a task. But a functional baseline is how someone's functioning is impaired. So for lower body functional baseline testing, it might be something like hopping or walking or stair climbing or doing a squat. In the verbal history, in part 1 of my evaluation, if the patient mentions his or her knee pain, for example, is worse with stair climbing, then I may just get out the step or we'll go to the stairs. I'll offer that we can go to the stairs to do that as a functional baseline test. We may do more than one, time permitting. It's also nice to have more than one functional baseline that you can say, this is problematic in my daily function. And so we have more things to go through to see if we're improving or not by checking things off that list. But like I said, for the lower body, there are any number of functional baselines that we can take. If I don't hear something in the verbal history that's obvious that I can test in the clinic, like a squat or a step up or jogging or walking, then maybe I'll ask at the end of the baseline taking or end of the verbal history, what can we do in the office right now that would recreate the symptom you're complaining of? And that's why functional baselines can be so powerful, is because it can really relay or relate to the patient's normal life. Every time I go up and down the stairs in my house, I feel my Achilles. Great, let's try that. Then let's do some testing, probably repeated movement testing, because that's the only testing that I would expect to give an immediate change. Let's do that repeated movement testing in part 3 or other types of tests, and then retest not only that functional baseline of stair climbing, but also the other baselines like range of motion and strength that we took in part 2. I mentioned some of the lower body. For the low back, it could be rolling over. It could be rising from a chair. It could be all those other things the lower body functional test could be. It could also be something like a yoga pose. I can never get into this position because my low back just doesn't rotate like that. For the upper body, I'll often use kind of reaching. Some patients will say, whenever I reach this specific way, I feel it in my shoulder or my chest, maybe putting on a shirt, tucking in a shirt behind you, getting out your wallet in your back pocket, doing a push-up, lying on that affected side on the bed or on the plinth. Again, we're looking for something that's more consistent in that patient's life. If it's inconsistent, it's not really helpful as a baseline in the office for testing. It's definitely important to note if inconsistent symptoms get better throughout the days or weeks at home. But in the office, I'm really looking for something that's consistently reproducing the patient's symptoms, because that will give us more of a cause and effect answer. If it's inconsistent, obviously, then we don't know if it's just changing because it's inconsistent or changing as a result of the cause and effect repeated movement testing that we're doing often in part 3. So if lying on your shoulder is consistently painful after 10 seconds, I'm going to have that patient lie on their shoulder for 10 seconds, see what it feels like. Then we will do a repeated movement test, for example, and retest lying on that shoulder. This brings up an important point. Repeated movement testing as an orthopedic test will or can show immediate changes in functional baselines. Many other tests are not designed that way. They're tests that are designed to give you a diagnostic answer, and then you apply the treatment. And you would not expect, for example, that tendinopathy treatment in the office, especially with the time constraints of an evaluation, you would not expect that treatment to change lying on that side in 5 minutes. However, repeated movement testing as a test, if we move the shoulder into extension 30 times and then lying on that side, now it takes 2 minutes for the pain to come about. That helps us understand that the likelihood of a mechanical joint derangement that responds to shoulder extension in the shoulder, that likelihood of that being the diagnosis is very strong. And that would give me the information, the confidence to prescribe shoulder extension repeatedly throughout the day, to continue that testing at home over several days. This is where the line gets blurry, however, because then that testing becomes the treatment if it's proven that repeated shoulder extension is what this patient needs to restore not only pain-free lying on that side, on that shoulder, but also all the other baselines that I found in part 2. So repeated movement aside, taking a functional baseline that's consistent is really helpful. And in all cases, I want to try to reproduce that patient's complaints in the office outside of just a range of motion or nerve tension test. And for most patients, nearly all, there's something we can do, even if it's as simple as rising from a chair or turning to pretend like you're looking in a car, kind of replicating cervical or neck motions that are a little bit different than the standard test. There's almost always something we can do in the clinic that will give us a really good baseline to use with our cause and effect testing. And even if we don't use it with our cause and effect testing in the moment, it's going to be something that we will monitor over the course of care, meaning, is this treatment making your function better? Is this treatment making your ability to hop on one leg better, or roll over in bed, or reach down and pick up your bag? Those functional baselines are really important. I argue, however, that pain and function are not the only two things we should be looking at when it comes to whether or not orthopedic treatment is valid and helpful. We also need to be seeing, does it restore range of motion, strength, nerve tension, and other kind of more objective biomarkers or baselines, if you will. Focusing just on function and pain, I think, misses the understanding of whether or not a treatment actually reverses the disorder, because we want the body to restore to normal, have its normal musculoskeletal properties of range of motion and strength and nerve extensibility and muscle flexibility. But taking a functional baseline is a really important part of what I want to do. It's an important part of what I do and what I want to accomplish by using specific testing to see how those functional baselines change or don't change.